Good. Okay. I'm Erin Freeman with Ackerman Marketing and PR, and we appreciate you attending this media briefing about our community's current COVID-19 status and related information. Over the next 45 minutes, you'll be hearing from representatives of East Tennessee healthcare systems and hospitals about the following topics in this order. Collective hospital data updates from Dr. James Shamia, Senior Vice President and Chief Operating Officer from the University of Tennessee Medical Center. Emergency Department insights from Dr. Mark Brown, Senior Vice President and Chief Medical Officer from Covenant Health. Current effects on pediatric care from Dr. Joe Childs, Vice President of Medical Services and Chief Medical Officer from East Tennessee Children's Hospital. Vaccines and treatment therapies from Dr. Frank Berline, Chief Medical Officer from Tenova Healthcare. Dr. Berline is also speaking on behalf of Sweetwater Hospital Association. Staffing and next steps from Dr. Harold Naramore, Chief Medical Officer from Blunt Memorial Hospital. Within the time parameters of this briefing, these speakers will answer to the best of their abilities as many of the media's pre-submitted questions as possible. Once each representative has spoken, live questions will be taken during any time that may remain within the allocated 45 minutes. During that potential remaining time, the chat feature will be turned on, and members of the media, you may submit your questions there. Questions will be taken on a first come, first served basis. Please identify yourself by name and media outlet. Also, please indicate if your question is directed to a specific health system, hospital, or one of our 5 speakers. I will read your question aloud in order it was received. The briefing will end promptly at 10:45 a.m. At this time, I will turn things over to Dr. James Shamia.
So thank you. We appreciate everyone's attention this morning. I'm going to give some hospital data, some that I had access to specifically from our hospital, and a little bit that's broader. For those of you who've seen me present data before, this is going to be a little different simply because some of the focus, our current focus has changed. So I'm going to share my screen, except that it says that host disabled participant screen sharing. So we'll sit tight for a minute. Sorry. Okay, we're good.
Good. Okay.
Okay, you got a slide?
Yes, we do.
Okay, very good. All right, so I'm going to try to be respectful of time, go through this fairly quickly and hit some high points. So as I mentioned, the focus has shifted on the hospital side a little bit. We've talked a lot about hospitalizations and whatnot, but we have more patients in the ICU than we've had before. And what that means is that there are sicker patients in regular hospital rooms, not the ICU, than what we've seen before. So while I'm going to go through some of the standard stuff, we're also going to be kind of talking a little bit about kind of just staff beds and equipment, things like that. So these next few slides are going to talk about the East Tennessee region. And just so you know, this is what these are the counties that are within that East Tennessee region. So what I want to do is compare and contrast the winter surge versus the current surge of COVID patients. And so here, just visually, what you see is as we were in December and early January, the rise in cases was what I've circled there as about what I'm about to show you was very gradual. And so it kind of smoldered. It was bad, but it kind of smoldered. What we're seeing this time around over the last 30 days is a much steeper rise. And actually that extended well before the last 30 days. I'm going to now break that down into how those two look a little bit different. So what you see is I've compared the winter peak to just a few days ago, September 13. So this time across that East Tennessee region, we have 61 more COVID patients in the hospital than we did in the winter peak. We have 31 more patients in the ICU, and very notably, we have collectively 33 more patients on the ventilator than we had during the winter peak. So this, for us, does look distinctly different. And so now I'm going to move to, let's just talk about kind of ICU and ventilator type stuff. So here you see this is a one moment in time snapshot about ICU beds. And so you see that this was the state of Tennessee from their website, and then the East Tennessee region on the 13th. And so 6% beds available in the state of Tennessee, 2.5% available, or 6 beds at that moment in the East region. You have to understand, because I think people end up focusing on this, that this is always in flux, minute to minute, hour to hour. And that was true even pre-COVID. This changes throughout the day, but we do have a capacity call of the health system 3 times a week on Zoom. And it's not uncommon that at that moment at 1 p.m., that we don't have ICU beds in the community. So it fluctuates, but my point is that is something that we focus and talk about. Another way that this is different, and this is data from our hospital, but I'm going to show you kind of a summary of everybody together on the next slide. What I did here is I picked July the 10th because that was a day where we only had 5 patients with COVID-19 in the hospital. And I took our ICU beds and then our patients on the ventilator. And you see on that day in July, we had 2 COVID patients on the ventilator and 31 non-COVID patients on a ventilator. But then 2 days ago on the 13th, we had 35 COVID on the ventilator and 29 not on the ventilator. So effectively what that means is that right now, 70% of our ICU beds house patients who are on a ventilator or a breathing machine. Whereas when we didn't have this amount of COVID, it was 36%. The reason why this is important is that if patients are on a ventilator and they survive, that's going to be very resource intensive. They're going to be in the hospital longer, in the ICU longer. And this is very dramatic in terms of what we're all seeing as far as how many of our ICU patients are actually on a ventilator. This is just the summary of data that I was provided from the other systems that rolls it all in together, basically. And so this is just a summary of this last slide for everything that was available for the system. So it's consistent across the board. So then just a few more things to talk about. So what are the downstream effects of having more sicker ICU patients? Well, we just had to realize that not all ventilators are capable of doing the same things necessarily. Some are simple ventilators, some are very complex. We know that critically ill patients are more likely to develop kidney failure. And so then they may need temporary dialysis. And so what you hear about in the media from a day-to-day basis, it's all about ventilators. And we do have a good supply regionally of ventilators, but you don't hear people talking about dialysis access and things like that. The next thing is that if this many patients are on a ventilator or a breathing machine in the ICU, that means that sicker patients than normal are outside the ICU. And I think we're all experiencing this. And so there's a domino effect that's created. And then finally, it is harder to create extra ICU beds than to create extra regular beds because of the level of expertise, nursing expertise that's required to take care of critically ill patients. Then just on my last 2 slides, so this is just our data. I didn't get this for the whole region, but just to give a sense of how much our hospitals stay full all the time. We're always busy. And so we have 480 what are considered to be kind of general med surge beds, not ICU. And on that day in July the 10th, only 1% of those beds were taking care of patients with COVID-19. And then a few days ago, 28% of those beds. And so we have to put that in context that a disease that didn't even exist 2 years ago is occupying, patients with that disease are occupying 28% of our beds, but all the other patient population still is there. They still need healthcare. And then this is my final slide, just because I think the mortality question gets thrown around quite a bit. And so this is there is no perfect way to look at this, but again, this is for our hospital, which is the only thing I had access to. And this just goes the 17 months up to August 1st, and then the 1.5 month from August 1st. And it shows you that, now granted, that 17-month period, there were times of surge and times where we weren't seeing that many cases. But what it shows is we're experiencing, on average, more than a death a day from COVID-19. And so the mortality on this is still very much a real concern. And so I just close my prepared data presentation with just the idea that this is different, without question, than the winter surge. There are definitely, the need for staff beds, the need for staffed ICU beds is a real issue. We've got more patients on the ventilator than we had before. And so I wouldn't characterize this really as a hospital problem, although it is. I mean, we're all navigating those challenges, but I mean, there is an element of this that is a public health issue. Because we also know that because of this, there are other things, procedures have been deferred and the things you all know about and hear about every day. And so I know later, be happy to answer questions, but I'm going to attempt to turn this, I think Dr. Brown is next, and I'm going to attempt to turn the control back over to Aaron.
Thank you, James, and thank you, Aaron, and thank you to the community for inviting us to have a brief conversation with y'all today. I want to make a couple comments about the situation in our collective emergency departments. I don't have slides to share like James, but I am going to make some comments that I think will give you a picture of where we stand in our emergency departments. And tailing off of what James had said, our emergency departments are equally as busy as our hospitals are. And it's been a bit of a perfect storm. Not only are we seeing a dramatic increase in COVID-related symptoms coming through the ED, as you can see from the numbers that James shared, but we're also seeing the routine things that we would see at this time of year. And our EDs were busy before we had begun to experience this surge several weeks ago. We also are seeing some diseases that we don't routinely see this time of year that I'm sure Dr. Childs will speak about here in a second, with RSV, which is normally something we see more in the winter months, both in adults and children. And so we have seen an increased volume of patients coming through our EDs. At the same time, we're experiencing these challenges of patients and the volumes growing within our hospitals. So a couple of things to note. Not only are we as full as we have ever been, and some of our hospitals are seeing 2 times as many emergency department patients as they routinely see on a daily basis for this time of year. However, we are also experiencing longer wait times in our emergency departments, not only for patients to be seen because of the volumes, but also for patients to be transferred upstairs. When the upstairs of the hospital is full, whether it's a medical bed or whether it's an ICU bed, we have to have a bed to put that patient into. And it is taking much longer for all of our health systems to get patients out of the emergency department that normally we would transfer out in relatively short order. So we're caring for patients longer in our emergency departments, which then backs everything else up. So there are a lot of factors that are going into the new reality of the flow in our emergency rooms is very different than it routinely is, and candidly different than any of us would like it to be to serve our communities best. A couple of things I want to highlight. Number one, if you are experiencing an illness with mild symptoms, especially mild respiratory symptoms, we really are encouraging you, all of us, to seek alternative places to get your care. There are many good urgent cares across our communities. There are drugstores where there are urgent cares available. There are telehealth visits, there are your primary care visits, et cetera. If you come to the emergency room with milder symptoms, your waits are going to be longer. And we'll talk about that in just a second. So please, if you have the ability and you are experiencing mild symptoms, we ask that you don't come to our emergency departments for those type of symptoms. If you've been exposed to COVID or think you've been exposed to COVID and simply need a test and aren't having symptoms currently, we ask that you seek that test somewhere else. Again, many opportunities to get those tests across our community, and it's difficult to provide that service at a time when our ERs are filled with very, very, very sick patients. The flip side of that is if you are experiencing severe symptoms, if you're having chest pain, if you're having stroke-like symptoms, if you're having shortness of breath, or a new onset of symptoms that's new and different and severe for you and you're concerned, we want you to come to the emergency department. We do not want you to delay your care. That's what our emergency departments are there for. And as busy as all of our emergency departments are, We want to be able to care for you and will care for you if you are having those type of symptoms. So please don't delay your care because you hear that we are busy. We are here to care for you in those times of need. And I think all of my CMO colleagues would agree with that statement. We don't want you to delay your care unnecessarily. And lastly, and then I'll turn it over to Dr. Childs, be patient and be kind. All of us, when we're sick, are not always our best selves. And our staff are extraordinarily busy. They are extraordinarily tired, and they are doing their absolute best every day. And they are truly the heroes in this circumstance that we're working through. And they're on the front lines. And we have folks who have stepped up and worked extra and worked long. And so we're doing our best every minute of every day across every health system in the community to meet your healthcare needs. So please understand our situation, work with our staff, know that people who arrive after you may be seen before you if they are sicker. We triage patients in the emergency department, and the sickest patients come to the top of the list. So please understand that and be kind and work with us to make sure you get the best care that we will provide. And with that, I will turn it over to Dr. Childs.
Thanks, Mark. The situation at Children's is in some ways similar to what Dr. Brown is outlining, but in some ways very different. We have seen tremendous volumes in our emergency department, in our urgent care, and our outpatient testing center, and in community pediatricians' offices. That has tapered some, but still very busy over the last 2 weeks. Now, not all these patients that are diagnosed with COVID end up in the hospital. Certainly not very many at all, and not very many end up in intensive care. Right now, we have 11 patients in the hospital with COVID, and we have 2 in our pediatric intensive care unit. The risk factors that we see that lead to more critical illness from this virus in our age group are chronic illnesses such as heart and lung conditions, some genetic conditions, diabetes, and then especially those that are challenged by obesity. That's definitely a significant risk factor. I do want to mention a couple of other things that we want to highlight right now. First, in the previous surge, we saw about 35 patients with a rare complication of having had COVID. It occurs a few weeks after you've had it, and that's MIS-C, or multi-system inflammatory syndrome in children. It is highlighted by fever and then a lot of systemic symptoms, especially abdominal pain, rash, but quite varied symptoms that appear just out of the blue. But it can make children very sick, and it can affect all ages. We have seen 2 patients with it now in this surge, and I know that community providers are alert to this, as are urgent cares and emergency department. But we want the public and parents to be alert to this possibility as well. It's rare, it's treatable. But if your child has unexplained symptoms and they are sick, that it's important that you seek contact with your provider, or after hours, seek care, urgent care, or in the emergency room. One other thing that I want to highlight is that our patients, some of them at least, are eligible for monoclonal antibody infusions. And so once you turn 12, and if you have high-risk conditions, this is an important treatment that before you're hospitalized, that can prevent the illness from progressing to the need of hospitalization, and certainly preventing critical illness. We've treated over 150 patients with this so far. Only a couple have had to come in the hospital, but they've had mild courses. So we're very pleased at some very high-risk patients during this time of very high COVID case rates in the community, that it's something that can keep these high-risk patients from progressing to a serious illness. Finally, I know Dr. Berline is going to talk about vaccination, and certainly not all of our patients are eligible for vaccination. But I think the most important thing you can do right now in your household, if you have kids that are at risk for COVID, or kids that you certainly want to prevent this infection, is to vaccinate the adults that are around them. So parents and household adults need to take that option to vaccinate. We will track the trends on vaccinating, especially as the potential age moves younger, and make comments about that as they come up. Dr. Brown mentioned that we're busy with other things besides COVID-19, and certainly that's true. It's a lot of winter viruses are here right now and making kids sick as well. So our hospital is busy. Our hospital is on most days is relatively full, but we are able to take care of kids that get ill for whatever reason, and we're here for them. I'm going to pass to Dr. Berline now, who's going to talk about vaccination and other treatments. Thank you.
Thank you, Dr. Childs. So yes, I'm going to speak about the vaccinations. As you may be aware, we've had vaccinations available now for over a year if you count the clinical trials and then the widespread use since the end of last year. Over 1.2 billion doses of vaccine have been given worldwide. And we continue to monitor and look and see what these vaccines are doing. A recent study cited 6.2 million vaccinated individuals and found that there was no increase of significant death or any significant mortality with these vaccinated people versus the unvaccinated population. Numerous peer-reviewed articles have looked at this, and scientific studies have proven the effectiveness and the safety of the vaccine. The chief medical officers here today have overseen over 200,000 doses of vaccine in our community without a case of someone having a significant adverse outcome. So we believe that the vaccine is very safe and very effective. We ask you that you please avoid the misinformation on the internet, follow the scientific evidence and the information provided to you by our own personal experience of your friends and neighbors that have been vaccinated in order to protect themselves in our community. Trust your doctors, your healthcare individuals, seek their help and their advice on this. While vaccination numbers in metropolitan areas are typically higher, yet still inadequate, as we are currently about 57% in Knox County, we are increasing, and that's hopeful for us. But it's also the rural areas where vaccination rates are somewhat lower, and they're also feeling the effects of COVID. Hospitals like Sweetwater Hospital are seeing more than half of their patients admitted with COVID. This has stretched their resources to supercritical values. The rural hospitals are sustaining care for patients to the best of their abilities, but with urban hospitals filled to capacity, as Dr. Shmia mentioned, there's just no place for these patients to be transferred. In the short term, wearing a mask can reverse the trend, but ultimately it will be the vaccine that prevents unnecessary morbidity and mortality. Our staff members are tired and to some extent frustrated because they know that the vast majority of the disease could be avoided with a vaccination. Also, there's been some discussion about, well, if you've had COVID in the past, you need to get the vaccination now. Studies have shown that if someone has had COVID in the past, that the vaccination actually doubles their immunity levels. So yes, even if you've had COVID in the past, you still need to get the vaccine. I want to switch a little bit now and talk about our treatments of the monoclonal antibody infusion treatment. As Dr. Childs mentioned, it is available for children as well as adults. The monoclonal antibody therapy can help to prevent hospitalization or worsening symptoms. The infusion consists of a laboratory-made antibody that mirrors the antibodies of patients that have recovered from COVID-19. The research is showing that this therapy may limit the amount of virus in the body, helping symptoms and the patient's improvement sooner. Hopefully this is keeping patients out of the hospital. There's every indication this is happening, and it's one of the best things that we have available at this time. The monoclonal antibody therapy is approved for certain patients, though, and you need to meet these criteria. You need to have a positive test result for COVID, experience mild to moderate COVID symptoms, and be at high risk for progression to severe levels. This is for people not fully vaccinated or not expected to mount an adequate immune response with the vaccination. If you've been exposed to an individual infected with SARS consistent with a close contact with criteria by the CDC who are at high risk, et cetera, then you're also able to get this monoclonal antibody. There's a whole list of people who were trying to use monoclonal antibody and with that are considered high risk, age, increased body mass, et cetera. I won't go into those now. Those are available on the CDC website if you want to take a look at that. You know, I'll mention as well though is that if you're tested and have COVID and need to go to receive the monoclonal antibody treatment, we're asking that you look on the website of COVID-19tn.gov for a listing of available sites. As Dr. Brown mentioned, emergency rooms in our hospitals are relatively full right now, and it's better to go to some of the healthcare providers in the community rather than come to our emergency rooms and have to go through the wait while you're suffering from COVID. And then finally, I'll mention that Medic is also still accepting patients for COVID convalescent plasma donations that can be used on inpatients. So we encourage you to volunteer if you have recovered from COVID so that you can help others combat this disease. With that, I'll now ask Dr. Nairmore to speak.
I want to start out by thanking Aaron for hosting and our community for being willing to listen and to hear what we have to say. I also want to say that my colleagues have done an outstanding job of summarizing each one of their points. And it really sets up my talk. And my talk is the impact on our staffing. We are able to provide care for this community, and we're being creative in the way we do it, but we're all stretched. And our staff is stretched, not just our nursing staff, our pharmacists, our respiratory therapists, people that prepare meals, the people that clean rooms, they're all stretched. And before I continue, I think that it would be good if you know somebody that works in a hospital, take the time to thank them, because almost all these individuals could take jobs at higher rates of pay, particularly nurses can take very high contract rate jobs outside of our community. And they've chosen to stay here and to help this community at a time of crisis or near crisis. We want to avoid a crisis. And I'll talk at the last part about next steps and how I think we can do that together. But let me say that our nurses every day are being asked to work longer, harder. They're being asked not to take time off. They're being asked to take care of more patients, both on the floor and in the ICU than they normally do. And none of us are doing that because we want to do it or we think it's a good thing. We're doing it because we have to provide care for this community. It is not where any of us want to be, but we're going to need your help in order to fix that. I'll talk about that in just a second. I do want to emphasize one of the things that Dr. Brown said that I think is really important. Please be kind when you seek our services. There have been a number of episodes that we've all experienced with people being angry, sometimes using abusive and threatening language toward our staff. They really don't deserve that. Please be kind, be nice. We want to treat everybody that comes to our facilities with kindness, and we want to give you the very best care that we can. So please keep in mind, we're trying to do that. And we don't like delays in our ED. We don't like delays in getting people to rooms. I assure you, any more than you do, we all want to fix that. Now, for next steps, I'm going to say some of the same things you've heard already. Vaccinate, vaccinate, vaccinate. Please consider the vaccine. Please look at the science. The truth is the vaccine is a very safe vaccine by any standard. Truth is, if you take the vaccine or fully immunized, you very likely won't come to the hospital. And the probability that you're going to die is almost non-existent. Please make that choice. That will help our healthcare system. That will help our staff. Please wear your mask. Please wash your hands. Please socially distance. And please avoid large crowds. That's even more important if you chose not to be vaccinated. We don't want this to go any further. We've talked individually. None of us have a crystal ball about how long this is going to last or how bad it's going to get. But we can work together in our community to improve where we're at and to help all of us. We can help all of us now together. But it does require us working together to do it. And none of us can do it without your help. No amount of nursing can do it without your help. No amount of engineering or operational wizardry can do it without your help. We need our community to help, and we need them to help now. And I would ask that you ask yourself what you can do to help all of us. And remember, even if you're low risk, you still carry the virus. And maybe you carry that virus to somebody who's not low risk. You know, when you walk through our units and you see the number of people on ventilators, some in their 30s, some in their 40s, lots in their 50s that are process of dying because this is a very difficult disease to treat when it gets that bad. It's very sobering. So I assure you it's real. I assure it's occurring in your community, and I assure you we need your help.
At this time, we will take some pre-submitted questions. The first is for Dr. Shamia from Grace King with WBIR. Almost 2 weeks ago, you talked about there being a ceiling for healthcare. What does that mean in terms of care?
So I'll build on what Dr. Naramore just said. And so essentially, as he said, we don't really know how bad this is going to get or how long it's going to last. And so we're all doing these creative things, particularly around staffing, to try to continue to deliver the safe care, the care that's expected. But there's been National Guard in the community. There's been requests for federal resources. There's really not extra staff to bring in from outside of the community other than that. So there's only so much that we can do. And as you start to see the writing on the wall, as far as, as I said, more patients in the ICU, sicker patients in the ICU, that's why we need the community's help so much, because I think we could not be more committed to problem solving around these issues that we're facing every day, but we can't do it alone. And so all those things he mentioned from a community standpoint are very, very important. The last thing I'll say is we have to remember that this is affecting all patients. It is not just about COVID-19 patients. Access to care affects patients regardless of what their illness is. And so everyone, it is, as I said, it's a public health issue.
The next question is also for Dr. James Shamia. It is from Justin Mason with WATE. What is the ventilator and ICU situation in East Tennessee? Are they full?
Well, I think I addressed a decent bit of that in the prepared comments. So, I mean, there are ventilators, certainly. I mean, we're not out of ventilators. We have ventilators to use. The ICU bed situation, staffed ICU beds, is much more the daily challenge. So at any given point in time, we're actively managing our population of patients minute to minute, hour to hour in ways we've never before, just trying to make the puzzle fit so that we can get patients to the right side of care, but it's becoming increasingly difficult to do so.
The next question is for Dr. Naramore from Scott Barker with Compass. How has the sustained surge in hospitalizations affected staffing in terms of shift hours, days off, et cetera?
I think I touched on that a little bit previously, but I'll expand on it. It has caused there to be much less than time in days off. There's a lot more overtime. When people are working, they're asked to work very hard and to take care of a lot of folks. Our staff is tired. It is no secret that we have a number of staff that have decided to not participate in this. They're tired, they're worn out. That makes it more difficult for all of us to get staff. We have a national nursing shortage in this country already. COVID hasn't helped that. As Dr. Shamia alluded to, there's not staff to bring in. We are all doing everything we can think of to get staff, and we're all working together as best we can to help take care of folks. But there is no more staff to bring in. And when people talk about ventilators, and I think Dr. Shamia summarized it very well, the real issue is where do we get the people to take care of all the sick people we have? Where do we find the people to give the expertise and the level of care we all want to provide? And the challenges of that are very, very frightening, frankly. And I think that we need to do what we can to curb this getting worse. So again, I've heard the things aren't real. I assure you, if you walk through our hospitals, it's about as real as it gets.
The next question is for Dr. Brown from Cliff Hightower with the Morristown Citizen Tribune. Are you seeing more indirect deaths due to COVID-19 patients taking up hospital beds? Are other areas of deaths increasing because of this? For example, not being able to get a heart attack or stroke victims or other patients that may need emergency care or need emergency medical surgery or attention?
So the short answer is no, we have not gotten to that point. We certainly always have, but even more so recently, are prioritizing those folks who are the sickest. And all of the health systems here in the community and across the country do that every day. So as I said in my earlier comments, if you are having severe symptoms that require emergency care, we want you to come to the emergency department and not delay. You will get priority if you have that emergency need for emergency surgery, for emergency intervention, or emergency medical care. We are very, very full with both COVID and non-COVID patients, as James outlined in his comments. And so it is a challenge, but again, our staffs, and I'd be hesitant, I don't think anyone has mentioned this yet, not be hesitant, but I'd be remiss if we didn't mention the work of our medical staffs, who have also stepped up dramatically. Hospitalists, intensivists, surgeons, cardiologists, every specialist that you can think of has gone above and beyond to be creative, to care for their patients, and to make sure that they are chiming in to really help through this crisis. So our medical staffs have all done a spectacular job of being certain that we can care for those patients who have emergent needs, which are all of our priorities.
The next question is for Dr. Childs from News Talk 98.7. What are the pediatric COVID rates at East Tennessee Children's Hospital? Are these rates higher than any time last year? What kind of increase are you seeing with schools back in-person classes?
Well, first of all, if we're talking testing rates, we test several hundred kids every day in the practices, urgent care, in our testing center, in our emergency room. We have seen positive rates up to 25% that have been positive. And that is somewhat similar to what we saw back in the previous surge in the December-January timeframe. But the number of children that we're testing and the number of cases is higher in this surge than ever before. This surge is very much affecting the from birth to age 20 higher than the previous surge. It was unfortunate that this surge occurred starting in early summer in nearby states, and then in Tennessee, especially starting in July. So as school started here in early August, the Delta surge was here, and there's no question that as kids were around each other, and that it was inevitable that cases were going to go up, and we certainly have seen that happen. Maybe starting to see it level off right now. I'm not sure about that yet, but hoping maybe we're seeing some leveling of that trend of how much it's been rising in our age range.
The next question is for Dr. Berline from Justin Mason with WATE-TV. What are you seeing in terms of pregnant women and the vaccine? Are some hesitant? What is your message to them?
Yes, I mean, there is some hesitancy among pregnant women as well as the younger individuals of childbearing age. And my message would be that the American College of Obstetrics and Gynecology recently came out about 2 months ago in strong support of the vaccination for COVID and pregnant women. They found no ill effects to pregnant women from the vaccine. And conversely to that, we do believe that women who are pregnant are at high risk of having adverse outcomes. But, we've had a lot of pregnant patients who have suffered from severe disease, both here and across the state of Tennessee, who are unvaccinated. So the vaccine is indeed recommended for pregnant women. And then also the second part of that we often get as well, what about fertility? And there is no truth to the rumor circulating that has any problem with fertility. There's no studies that have been done, but there's also been no anecdotal evidence or anything that would indicate to us that getting the vaccine causes any fertility issues. And just like getting the virus also doesn't cause any problems that we know of as well either for future fertility.
The next question is for Dr. Shamia from Justin Mason of WATE. Here in East Tennessee, many of our viewers argue this virus has a low death rate and that we should just let it run its course. Many are even discouraging masking and getting vaccinated as well. With the recent rise in cases, what is your message to that group of people?
So I think my most immediate message, and I think anybody who's watched this can sense this, is we are collectively concerned about what's happening right this minute in the healthcare delivery system. And so while absolutely vaccination is, we feel the longer term path through this, having mitigation measures in the community, increasing those is also very important. And what I say is if you start a vaccination series now, it'll help protect you in 6 weeks. If you wear a mask a day today, it will help protect you today. And so that's the first thing. The second thing, though, is that what we're seeing essentially in our community is that we're all tired, and everybody is tired of not just all of these different measures, but just having the conversation, quite frankly. And we understand that. But at the same time, the healthcare delivery system cannot sustain. This cannot be the new normal for the healthcare delivery system. This is not something we can do this now, and we're expressing that. But this is not something that we can do long term. And so the final thing I'll say is there may be some sense in folks that this is kind of the race to herd immunity, that we'll just let it run through here and it'll finally be behind us. And I hope that too. I hope that once we get through this, whatever it looks like, that we can put this in the rearview mirror. But I don't think we know that to definitively be the case, that that's what's going to happen. And so we on our side want to be able to learn how to manage COVID-19 and the community manage it to minimize the individual harm, both to patients who have COVID and then the rest of the patient population as well.
The next question is for Dr. Childs from Vincent Gabriel with the Knoxville News Sentinel. It's a two-part question. What advice do you have for parents of children who are too young to be vaccinated? And we're a little over a month into the school year for Knox County schools. What would you urge the school system to do to protect kids who are getting sick at a higher rate than ever before?
Well, I think first of all, may have mentioned this earlier, but the most important thing you can do to protect children who cannot be vaccinated yet is to vaccinate yourselves as their parents or adult caretakers. That has been shown to be very effective at lessening the rates of pediatric cases. As far as kids in school, I think when cases are this high, I think parents, I really urge parents to strongly consider masking their children as they go to school. I don't think that's happening in any appreciable number from anecdotal comments that I hear from people that work in schools or from parents or from kids themselves. But I think that's a missed opportunity to try to prevent the spread of this while waiting for the vaccine age to move down to perhaps age 5 soon, and to try to prevent pediatric cases. We know pediatric cases tend to not be as severe, and that's certainly been our experience, but they're not totally without risk. And so some kids that have profound health issues can have trouble with this virus and need help in the hospital, need help in intensive care. So we want to try to prevent the spread. And I think the number one way to accomplish that right now are mitigation measures that were mentioned. But when you're in close quarters with other kids, or when any of us are in close quarters, the mask is very important.
Okay. Once again, thank you all for joining us today. Thank you for your time and attention. This concludes the media briefing.
Thank you.